Well, I wanted to welcome everyone to tonight's ASES research webinar. This is the third installment with regards to the research webinar series. This was initiated with the idea to hopefully be able to get residents and fellows, as well as surgeons in practice, engaged with regards to both basic and clinical science research associated with shoulder and elbow surgery, to hopefully be able to then stimulate better or improve submissions to conferences, to the annual meeting, as well as for grants. And so tonight it's going to be focused on clinical research, specifically on how to set up and run multi-center studies. We've got three talks. The first is going to be by Carolyn Hetrick on organizing multi-center clinical studies. The second is going to be by Andy Jawa on study design and the Delphi process, and Andy's got a lot of experience doing that. And then the final one is on by Eric Ricchetti on multi-center study opportunities through the ASES, the current opportunities, and how to get involved, specifically because Eric's been highly involved with the ASES Multi-Center Research Committee. So with that, we will start with Carolyn on organizing multi-center clinical studies.
Thank you for having me. I am, as you said, going to talk about how to organize multi-center research group, and both from the standpoint of a leader as well as a participant. And I want to give credit to Jed Kuhn, as a lot of these are his slides. So there's a big difference between leading and participating in a multi-center research study. And again, we're going to touch on to these. We're first going to discuss what it involves to lead a multi-center research group. And these are a lot of the lessons that I've personally learned from the Moon Shoulder group. So what is Moon Shoulder? So Moon Shoulder is the Multi-Center Orthopedic Outcomes Network, and it's a research consortium dedicated to conditions of the shoulder. We have 18 surgeons at 11 sites. And we do this because we recognize that the best research comes from high level of evidence and from multiple surgeons with large populations. So you really need those patients' numbers to be able to look at a large number of variables from your statistics and to make a lot of conclusions. So we had the Rotator Cuff Center, which is the kind of the first study that was done out of Vanderbilt with Jed Kuhn. Brian Wolf and myself did instability. We have a throwing shoulder and elbow study that started out of Vandy by Eric Bowman, and shoulder arthroplasty that's getting going as well. So these are the steps to leading a multi-center study. It's finding the right people, establishing the rules, defining the mission, determining the outcomes of interest, assessing accuracy and reliability, reducing practice variables, developing your database, cataloging your protocols, and doing all the IRB stuff, funding, and then planning for the future. So in Moon Shoulder, it first started in 2004, but in 2006, they had the first meeting for rotator cuff repair. It took them 2.5 years before they collected the first data for rotator cuff repair study. In July of 2011, we had the first meeting for instability, and a year and a half later, we had our first patient enrolled. And it wasn't because we necessarily did anything faster, but we were able to use rotator cuffs, surgical forms. We just had to modify them. The group was already in place, so we were able to get things done a little bit quicker. But the point is it takes a while to get these studies going. You have to find the right people. And the big thing that's been said by Jed, Kurt Spindler, is you should have no or suppressible egos, and probably want to avoid big names, because you really do want people that this is going to be their primary thing. You want academic people at maybe non-academic places, understanding the power in numbers. And the big thing is you want everyone in the group to be someone you would have a beer with, because you're going to work a lot with these people, and it's important that you actually like them. They must have some kind of research support, and that doesn't have to be a research assistant. One of our best participants in the study is in private practice, and he at first just had his administrative assistant did it and do all of the work for him, and she was excellent. And so they just have to have somebody that's dedicated to doing research. And then for us, they had to put Moon first. We really wanted them to kind of have that be their focus. The next step is to sit down and kind of establish the rules and establish what citizenship looks like for your group, and that's authorship, participation, follow-up, access to data. And a lot of this comes down to, is it the carrot or the stick? And oftentimes it's kind of both at once. And you have to carefully come up with a balance of how much carrot and how much stick, and that kind of changes over time. And these are some of our rules for instability. And so for authorship, they have to enroll a certain number of patients. You have to review and approve the manuscripts. That's required by the journals, and just makes sense. You have to maintain a certain amount of follow-up. You have to participate in half of the monthly calls and at least one in-person meeting per year. For abstracts, again, you have to send it to the group before you submit it for everyone's approval. Manuscripts, it's a little bit more, we need 2 weeks, and everybody again has to approve the manuscripts. And we require having a statistician do all the data, and then musculoskeletal radiologists to do all the imaging, just because we've put so much into it and we want, again, the best quality. For presentations, we require that it's on a Moon background and not the individual institution, and that all surgeons and staff need to be acknowledged, and that in the past, unfortunately, hasn't done, and it leads to some feelings getting hurt because people really do see this as a group effort. And again, we have rules for accessing data, submitting FINER forms and variable request forms, and then what you can do with that data. So next, after you kind of get the rules of the group and define what citizenship looks like, you have to develop your research questions. So what does the group want to study? Oftentimes can look at it with a FINER form. Is it feasible, interesting, novel, ethical, and relevant? Is it fundable? So, as a group, they decided to study rotator cuff disease first. And then you also have to then decide if you want to do a randomized controlled trial, or if you want to do a cohort. My personal preference is to do a cohort at least first, but there's good reasons for both, and that's its own talk on its own. Step 4 is you want to determine your outcomes of interest. And this is one of the things that I think you need to spend the most time doing. It's one of the things that leads to the most regrets afterwards. I think everybody, when they go to analyze their data at the end, is like, oh, we should have asked this, or we should have done that. And so it's really worth taking a step back and being very, very thoughtful on, what patient-oriented outcomes do you want to include? And so this is the list for Moon instability, and it's a lot. So it's a high patient burden, but we wanted to make sure that we had, something so we can do cost utility analyses, so that we could do psychosocial, you look at psychosocial impact and things like that. There's ways now to do this better with some of the adaptive testing that can be done and with PROMIS, but this is what we kind of came up with at the time. It's also important to think of things and make sure you have a general health measure, a limb-specific measure, if you have a disease-specific measure, an activity level, what you put into it. And then you have your objective measures and how you're going to collect these, and how you're going to collect your MRIs and whatnot. You want to determine the accuracy and reliability of the data that you're going to collect. And you have to do a lot of literature searches for this. And if it isn't out there, you have to do some studies beforehand. And this is what takes a lot of the time. So there are agreement studies for us. We're on MRIs and looking at arthroscopic findings, literature reviews to see if there was a best physical therapy protocol or for indications for surgery, and decisions on patient-reported outcomes. This is one that we did for, again, Moon instability, looking at inter-observer agreement for the assessment of labral tears. We looked and see how well people agreed, looking at, arthroscopic videos. And this is kind of a list of things that were published when looking at accuracy before starting the study. The next thing you want to do is you want to reduce your practice variables. And so look at the things that you can kind of standardize amongst the groups. So that can be, x-rays, physical exam tests, classifications. And if there's no data, again, you might have to do the studies. And for us, we standardized the post-op care. So when they could shower, things like that. The physical therapy, the radiographs, those are the ones that we got. And then what slings you use. And because those were things that were easily agreed upon. And you might have to do some systematic reviews. These are our physical therapy protocols between instability and rotator cuff. And we used to have them all printed out in booklets, and that was actually pretty expensive. But now, everyone's online. So we have them on the internet on our website. It drives a lot of traffic to our website. And also, is easy to access. Next, you have to figure out your data management. So that's done by the coordinating center. It's done electronically now. You have to decide on a data collection platform. And that's one of the most common questions I get. Should we use REDCap, OBER, SOS, et cetera, Epic. You'll have to look at database development and management. and get biostats involved early. So get a statistician involved to look at it, because you'll avoid a lot of headaches, later on. Then you have to do, once you kind of get all these things, what you're going to collect, what you're starting to develop your forms, you have to make your manual of operating procedures. And ours is 80 pages long. So this is a significant amount of work. You can probably get one from another group and then modify it for your project, but these are a lot of work. They're required by the IRB. And to kind of put this together with all of your study protocols, you have to then get your IRB protocols, and you can either do a central IRB or you can do individual site depending on what you have access to. And if you can do a centralized IRB, I think that that's the way to go, but we do not have that. And then you have to register your trial with clinicaltrials.gov. Next, you get to funding. So how are you going to pay to do all this great research? And this is the most difficult part. And this is the part that I've struggled with the most. Things that you can do to get going is you can do a personal tax. And that's what they did at Vanderbilt. You can try to get some industry funding. You can apply for grants for ORAF, which we were successful with. Try to get society money. And then, the Holy Grail is trying to get NIH, DOD, or PCORI funding, because it's larger dollars but that's very tough to do. Next is collecting data and planning for the future. So you have to start collecting your data. You have to start worrying about follow-up, again, funding. Start thinking about your next project. It's never too early, but it takes, a couple of years to get things going. You don't want to have that gap. Consider the time as an investment. Small grants should fund pilot data for large grants, and no dead end projects. So, there's a lot of lessons that I've learned from this over the past 10 years doing this with moon instability. Again, finding the right people is important, and really people who are going to work well and work collaboratively and have this be their priority. The leader must push the mules. That's how Kuhn looks at it. And you have passion and time, and you have to push for follow-up. Preparation is key. You have to maintain enthusiasm. So moon shoulder instability has been going for 10 years, and people were super enthusiastic at first. And, now we're in the follow-up stages, and it's trying to keep people engaged. They make their follow-up calls, and they keep doing it and keep up their last little bit of enrollment. It's hard, and it's hard because it's been going for such a long time, but you have to keep up that momentum. And then there's difficult decisions. So sometimes along the way, there might be a site that's not, doing so well in terms of follow-up or in terms of participation. And you might have to, get rid of a site. There's been people in the past who've had to actually kick out their mentors. But you have to do it to protect the integrity of your research so that you have, higher level of follow-up, so you can have research with fewer biases. And it also protects the good citizens in the group, because if you think about it, there's people that are working hard that really are making this a priority, and you don't want things to be degraded by someone who's not. This is how I look at it. I look at it in terms of herding cats. It's in terms of getting people to make their follow-up calls. Surgeons have a lot of different things on their plates between practice and life and sports coverage and society stuff. And so asking them to do things on your timeline can be tough, but it's worth it. So the payoff is you make great research that can change patient lives. There's a lot of academic success for promotions. You get tons of presentations. Rotator Cuff has done 20 plus publications. Instability, we haven't even gotten our 2-year data out. We have 21 publications. We just had number 22 approved today. Rotator Cuff has had 2 NEAR awards. And the biggest thing I think from it is great relationships with friends. We really do have a good time with the people that you work with, and really do enjoy kind of discussing everything with them. So now I'm going to shift gears just really quickly for this next part for participating in multi-center research. And it's from the same thing. Why participate? It's the exact same reasons as before. You work with great people, you get publications, presentations, et cetera, NEAR awards. It's the same whether you lead or whether you participate. As a participant, what's required? This should be the most important research you do. You should be able to dedicate yourself to it. And, if you're going to do some time with research, why not contribute to the highest level of research and make a difference in patient lives? Clinical research can have more and faster impact than basic science. And a multi-center research group is the most efficient way at generating manuscripts. And again, you have to look at this as teams over individuals. You have to check your ego at the door. You have to be malleable. So when you meet, you meet like we did our physical therapy by consensus. So we had to take everyone's physical therapy protocols and combine them together, which meant that no one had the physical therapy protocol that they exactly wanted. And you have to be willing to make those, make those concessions, maybe change your x-rays, do things that, change your practice. And as you know, again, surgeons get pretty stuck in their ways, and you have to be willing to make those changes. You may have to pay to play. So you might be at a place that assesses a tax to pay for research. It'll make you a little bit slower in clinic when you're enrolling people. It'll tie up your rooms a little more. You need someone to help with your research efforts, whether that be a research assistant, admin, nurse, PT, whatever. And you may have to attend more meetings than you otherwise would have, because it's important to meet as a group and to have those relationships. You have to be engaged. Again, it takes time. So you have to, monthly conference calls are tough, because if they're in the morning, that usually means it's ridiculously early for the West Coast and cutting into your clinic time on the East. You have to enroll patients. You have to call patients for follow-up, because that's how you get that 80-85% follow-up. You have to complete your forms, and we require it's done by the attending and not the fellow. And, that again takes time, and you have to turn manuscripts around quickly. You have to be responsive, and so do things again quickly, and it has to be you and not your your administrative assistant. So again, why should you do this? It's because you have passion in finding the answer to the question. And if you don't have passion, you probably shouldn't, participate, because it is a drain on your time. And I'd be happy to answer any questions that anyone has.
That was great. Thank you, Carolyn. Amazing talk. And it really stimulates some good questions and discussion. And, I have several, but the one thing, at least I'll start with trying to get your thoughts, is that a lot of the research that we do as surgeons, we drive the research because it's ours. So for instance, if I am looking up 100 of my patients after X procedure, we do all the work, we get it published. We know that this is Bob Tashin's series of patients that he's following. In multi-center studies, you just outlined, there's a massive commitment for every single person that's on that team, but it's not necessarily, theoretically, it's the team being recognized, but usually there are certain leaders, i.e. you and Jed, Brian, et cetera, that have kind of taken a role with regards to leading this. And obviously there's a larger amount of work that as the leaders of the group have to put in, but there's still a massive amount of work that the individuals. So how do you manage that? Because to get someone to commit to something where they might be the 30th author on a paper in the middle of a morass of other authors, that they have no idea. They know that they know the rotator cuff work is Jed's work. They don't know that it's Surgeon X in the middle of North Dakota that has spent a massive amount of time committing to this project. So how do you manage that? How do you keep them engaged? It's a tricky balance, because it's a very different type of research than a lot of the other clinical research or even basic science research that we do. That so it'll be interesting to hear what your thoughts are.
So what we decided to do is we decided to share some of the authorship more. So, again, even though Moon, Shoulder, and Stability was initially started by Brian and I, we don't take senior author on every patient, every study. We allow the sites to kind of take ownership of that. And then our names get thrown into the middle to allow everybody to, have that data to present and have that data that they can kind of take ownership of. I would say that overall, you have people who participate who understand that when you can enroll 2,000 patients and that you can analyze more and you can have kind of higher quality data than if you just had 150 or 200 of your own, and really like being kind of part of that. That doesn't mean it's not tough, and that doesn't mean, like I said, that people their enthusiasm doesn't wax and wane in terms of the amount of effort they put in. But I
Sure.
think that everyone, at least in Moon, kind of sees the greater goal and sees what can be produced, and really buys into that, and it has been really fantastic. And we do still list authors, and so if you look at Mars with the Rick Wright study, they went to a single thing, so they don't have a single author's name listed. It just says Mars Group. So there really is almost like completely anonymous participation, and so you really then have to buy into that concept. But I do think that's where it comes into the checking your ego at the door, and really just wanting the highest level of science.
Sure. No, I understand that. And I think to check the ego at the door, it totally, I am in complete agreement. And partly it's because I'm part of groups that I do the same thing, that I have no interest in being known as the person that's leading this or being part of it, but I'm still engaged. But there's an element of human nature that is that if I'm going to invest a tremendous amount of work, that I want to be recognized for that tremendous amount of work that I've placed. And so it's interesting. Yeah, it's challenging. Other thoughts, Eric or Andy, any questions for Carolyn?
Well, I think to add to the points you guys are talking about, I mean, the Moon groups have done a great job of it. You're talking about, trying to get everyone to contribute together, and, what the Moon groups have done over time, I think allows different people to get more or less involved in different projects. And I think that's the ideal with a big multi-center group. As you collect bigger and bigger data, one person can't figure out what all the questions are. So the group generates, tons of questions that each give different people opportunities to take leads and be more or less involved in different projects. And I think that's the ideal if you have a really successful group like Moon has been over the years.
Sure. Also, I mean, the part of it is that, probably one of the best ways to be able to initiate this type of research is to be part of it first. You listed all the things that were the requirements, and then it's like anything, you don't become the captain of the team until you actually are the guy that's the gal that's in the trenches at the beginning. And I think that you learn a lot by doing. And then if someone really feels that they want their own child, they can create their own group and go forth and kind of do the same work that they were participating in. So I think there's an avenue to being able to do it. And I think that it's probably a good strategy. It would be interesting. Had you ever run a multi-center group before, or do you know if Jed had run a multi-center trial or multi-center group prior to Moon Rotator Cuff?
I don't believe he had, but I'm not sure. And I had not, but I had participated obviously in Moon ACL as a fellow, and I participated and observed, Moon Rotator Cuff as a fellow. But and I was new into practice when we started instability, but I at least had the mentorship to help me, and that was the most important part for me with Jed and Kurt.
Yeah. Go ahead, Andy.
Yeah, no, I just want to make a comment. First of all, Carolyn, that was an awesome talk. I wish I had it 4 years ago. And you really knocked every single point where I'm like, yeah, I wish I knew that. I mean, it was really well thought out and shows a lot of experience. And what I really want to highlight is, I started with this multi-center research, which I'll be talking about in a moment. And I sort of learned all those lessons the hard way. And I think you're spot on. And you guys are sort of professional at it. I would love to sort of pick your brain, and I'm sure lots of people will be picking your brain after this webinar on how to do these things. So that was great, especially having the right people in the group, the people who are going to participate. And that leads to Bob's question, which I really struggle with. So as I'll talk about, we have this multi-center group where everybody's doing a ton of work, but I presented at the last ASES, which I feel really guilty about, frankly. And so how do you do that is still something I'm working through. I wonder, Bob, if you have any thoughts on that, but doing exactly what you say is having other people start being leaders, start, having, learning. I've learned how to do it, then you sort of pass it on. And and that's how everybody grows. And if somebody wants to take a leadership position, that's great. But I think it's important to have people who don't know how to do it start learning on their own, and there's sort of hard knocks.
Yeah, I mean, I think personally, I think it will find its way a little bit, in the sense that if someone has the bandwidth to become a leader in the group, then the key is giving them access. And so what I think where the rubber hits the road is if there's no access, then that's where frustration occurs. If Surgeon X or Surgeon Y that's in the group, one person, their bandwidth is so tiny, they're just happy to be part of it and be able to get the get everything completed and taken care of. I think that that's the type of person that's not going to worry about being on the podium or whatnot. Whereas there might be someone with a tremendous amount of bandwidth that would love to be part of leading a specific group and or a part, a sub cohort of the larger group. And I think the key is making those people aware that there's an opportunity for that. That's what I think, but I don't know. What are your thoughts, Carolyn?
Well, actually, I guess to add to that too, because Carolyn, I mean, you guys are a mature group. Have you created a mechanism that people are allowed to submit ideas and sort of the group reviews and vets them? Because I'm sure there's a lot of ideas and you have to sort of sort through what the best research questions are.
So we have them submit a finer form, and I know you're familiar with that, the feasible, interesting, novel, ethical, and relevant. I know you guys use that as Cleveland Clinic as well. And review those, and kind of works on a DIBS system, and it has in the past where if you come up with that idea and it's approved, you get access to that data. We've recently tied it as a carrot, since if you're making your follow-up calls and have better enrollment, we're giving people some kind of increased access to the data to try to positively encourage people to, keep calling patients and keep enrolling. I think that I think you have to have ways for people to get involved, and we have certain people or institutions who are kind of more interested in ladder shape, for example, or posterior revision posterior, and have their little areas within the group, or interested in the activity level stuff. And we let them kind of take that and run with it, so people can have that ownership, and they can have the manuscripts and the senior first authorships, and as well as the podium, be up on the podium, so that everyone can have that recognition and have those benefits.
Okay, it's great. Why don't we move
Bob,
to
there's one question from the audience.
Oh, sorry. Thank you, Eric. I really appreciate it. Great discussion. Thank you, Peter. I'm glad you're here, and it's wonderful that you've joined on. What methods, Peter McDonald, what methods do you use to convince patients to enroll in a multi-center trial, especially patients who are worried about being in an experimental protocol? Great question. We see this not only with multi-center trials, but it's most oftentimes we see it, at least I do, with randomized studies where every patient thinks there's got to be something better, and that one treatment has to be better than the other treatment. So I just got to somehow use a Jedi mind trick as a patient to be able to figure out which one you think is better, and that's the one that I'm going to tell you to actually do for me. And I think that the idea that that's why we're doing research needs to be emphasized to the patient. So for me personally, I can tell you that has been our strategy, is that I've actually told them the purpose with regards to the research specifically is that there is no clear answer as to which is superior or not. And because of that, there's not a choice. Engaging in a multi-center trial, that's different because of the time commitment as well. That's years of commitment. How have you addressed that to be able to get patients engaged to come back at 6 weeks and 3 months and 6 months and all those time points and fill out all their questionnaires?
I found it's pretty easy to enroll people in a cohort, because you're not changing standard of care and you're not, randomizing them into anything. And so most people agree. And getting follow-up, we're our research coordinator at our central, or at our coordinating center. She's able to get high 60, like 68 to 71% follow-up just on her own through sending out the forms and her making some initial contacts via email or the phone. But then it has to be the surgeons calling and kind of leveraging their surgeon relationship to, ask these patients to fill out their forms and to do it. We do pay $20 to $40 depending on the time point to kind of help with that. But it really is, I think, leveraging relationships and the surgeons calling in terms of follow-up. I think in terms of, the randomized control trials and getting people to agree to have their treatment randomized, that's really tough. And so if you look at like the ARC trial, where it's between surgery versus PT for rotator cuff tears, they have to screen 10 patients to find one who's eligible. They have to find 10 who are eligible before they find one who will consent. So they look at about 100 patients to get one into the study. And they looked at, who is agreeing to be in these trials and who is, and how, what's the characteristic? Is it money? What is it that's leading these people to agree? And it strongly was altruism. So people really wanted to play a role in finding the best treatment. And so it was hugely, like, not even close. It was the number one reason that these people had consented to have their treatment randomized. And so I would say that the best idea is to really try to play into that sense of altruism and how much that you will be helping kind of advance the field and know what's best. Because as Bob said, we don't know. It could be one of these two now, but with your help and with your willingness to do this, the next group of people that come through this, we will know the answer and you'll be able to help them.
It's interesting.
Bob, if I could comment on that, I just recently was part of a RCT, actually very similar to one you presented, PT versus no PT after RSA. And I felt at first I struggled to enroll patients because I didn't truly believe in the equipoise, because I thought you didn't need PT. And I hadn't been doing it for years. And it made me realize after, looking at, talking to other people who did PT, that I truly didn't know the answer. So I think surgeons sense, or patients sense, what you really want to do. And you truly shouldn't be, or in my opinion, I wasn't able to be part of that study until I truly believed that there was equipoise between PT and no PT after RSA. And once I sort of believed that, and I saw what was out there, talked to other people, I was able to consent patients to do that and say, I truly don't know, these are the advantages, these are the disadvantages. Until then, I wasn't able to truly enroll them to my comfort level.
Yeah, I mean, I think you got to feel comfortable as a surgeon in the research that you're doing. And if you're not, then, it's okay to say no. You should not have FOMO about, clinical studies, and that, it's okay. There'll always be another one that's going to come down that people are going to ask about.
Absolutely.
It's great. All right, why don't we move on to Andy's talk? So Andy is going to talk about study design and specifically the Delphi process, which is very interesting. We hear a lot about this at meetings. A lot of studies are actually designed this way, but it's there's an element of, is this who's the guy behind the curtain that's pulling all the strings with regards to what this process really is, and hopefully Andy will simplify it.
All right. Well, this is great. I maybe didn't take the curtain back so far. I talked a little bit more generally, but one of the things that I just want to say is, Carolyn and Eric are professional multi-center researchers at very high levels at very great institutions. I'm sort of the peon here and sort of figured it out, or not very well. And so this is sort of my experience of how I did this. I will be jumping into the Delphi process, but really my experience is really not having any experience running any multi-center studies until I was involved in the RSA complications group. So I'll be talking about design, the Delphi process, and what I learned. These are my conflicts. I don't think they're relevant. So first, a little bit about the role of multi-center research. We've sort of touched on that already, so I won't dwell on that. Talk a little bit about my experience with the stress fracture multi-center study as a case example, which will really be a theme throughout this. A little bit of a word about statistics. So I learned a lot about statistics in this process, and it really has affected me in terms of wanting to do more multi-center research and seeing the power of this. And so I'll give a quick slide on that. I'll delve into the Delphi process, what it is, how it works, give a couple of examples, but certainly we'll answer a lot more questions about that. And then really the momentum of collaboration and how it feels good and wants you to do more, and getting on to the next steps. So we've already sort of talked about this, the hierarchy of evidence, systematic reviews, meta-analysis of RCTs, and good data is the best. But you can do multi-center research for all of these, for RCTs, cohort studies, case control. And it's really good at looking at uncommon problems, particularly, not just sort of rotator cuff tears, which are common, but specifically, like we'll get into stress fractures, where we see it in, maybe 3 or 4% of patients, where any individual person's practice is not going to give us insight. It improves our statistical power, but also it gives us a diversity of surgeons and how we practice. And so how we use different implants, how that might affect it, diversity of patients from different parts of the country, how they might be different. And in theory, it could reduce bias, though sometimes baked into how we collect the data, there could be bias that's hard to decipher. So one of the things that came up when I started doing the RSA complications study group is we would meet at the academy or ASES, and I'd come up with a protocol, and then we'd talk about it, and it was really difficult to define consensus. And I wish I had Carolyn's talk. There was a lot of personalities, dynamics, the loudest person in the room. We'd talk about one thing, we'd come up with something, and then at the next meeting, we'd rehash something we talked about. So I found it really difficult to figure this out and how to lead. And it's also really timely, as Carolyn went into. Quality of data may not be good at any individual institution, and then or there's really you have to really check the quality of the data. And then institutionally, DUAs, data use agreements, can be very difficult at institutions. A lot of work to go through all that, some of the nitty gritty that Carolyn talked about. So we started off with this group, and a lot of great people here, but a lot of smart people with a lot of opinions. So we found it hard to navigate and to collaborate and to gain consensus initially. Maybe it wasn't so bad, but we started, and again, we really had no background. I had no background in how to do this. And so we first, at a table at the AOS, we said, let's start with a systematic review of the complications. That's modern. Not having 11% dislocation rate from 2006. And so that was a great way to build a group. And so some people didn't have bandwidth, couldn't do it. It really allowed us to congeal and basically come together, and the people who wanted to be part of this simple systematic review were able to do. And so that was a great to really get a little bit of consensus to get a group. And then we decided, hey, let's look at stress fractures. It's a big deal. We don't know anything about it. We know that osteoporosis is really the only thing that we have found to correlate. Let's dig into this deeper. The current literature, as you knew, it was small sample size, single institution, single implant. We looked at stress reactions, which is tenderness on the acromion, but no objective evidence of stress fractures. Do you keep that? Do you include that? Limited indications. If you look at sort of historically, there was 5 cases in 2011. This study had 33. We had 40, and this was a pretty big study that came out of the Rothman group. They had almost 2,500 patients. And probably the biggest one published in JBJS had 61 stress fractures. And so it's hard with thousands and thousands of patients to get a lot of numbers to make any correlations. And this is where statistics sort of came in. And I've learned a lot from Surgeon Warren Dunn, who's a fabulous statistician, is an orthopedic surgeon, and basically taught me how I've been doing stats all wrong. And this is one of the reasons why it's important to do multi-center research. A lot of us do multivariate model regression analysis to look at correlates to outcomes. The problem is you need to have, according to Warren and people who know about stats, you need to have 10 cases in a case control to put 1 degree of freedom in your analysis. For instance, if you had 10 stress fractures, you could look at age, a continuous variable. If you had 20, you could look at age and gender, for instance. So if you had 60 or 61, you could only look at 6. The problem is when you look at these papers, they include like 12, 13, 14 things, which leads to a model being overfit or inaccurate. And all the variables chosen should be chosen by an expert. So you can see how multi-center studies can be very powerful in getting better data. So this is what we looked at, these different factors based on having 180 stress fractures. And now I'm finally getting to the Delphi process. And so in order to get consensus, I sort of came across the Delphi process, and you have to have a question or a problem area, something that you're trying to get consensus on, have a group. You send out surveys that the key is it's anonymous, that it's a controlled feedback, and that's the key, having the control. So you have to have a person who's sort of dedicated to looking at this, thinking about it, summarizing the comments, putting it back. And it's an iterative process until you get consensus, and you have to define what consensus is. And so in this case, we're defining stress fracture incidents. What is our protocol? What are the risk factors? That was sort of the question. We had 21 ASES members. There were anonymous surveys, except for the person who was running it, which was me, iterative feedback. And, we had to get 80% consensus on any particular question. So let's go through an example. So very first survey that was sent out, a lot of words here, but I'll read it. Acromial stress fracture, scapular spine fracture. Defined as, and I just came up with this definition and we go from there, radiographic findings, fracture line, displacement or callus of the acromion or scapular spine after ipsilateral RSA on X-ray or CT. Agree or disagree with this? If you disagree, put it in the comments. We'll go back to the iterative process. Symptomatic acromial stress fracture is pain or loss of motion associated with diagnosed acromial stress fracture. So then we took this survey, sent it out to everybody. You need to have a certain number of people respond. We determined that to be 75%, and then you have 80% agreement. And we got 90% agreement, but there were 2 comments. So those 2 comments went back to another survey, and we had lots of different surveys with lots of different questions. And so because we had agreement, we went back in SurveyMonkey and said, hey, we have agreement, but the comments wanted to include osteochromiale and bone scans. Do you agree or disagree? And we got agreement. And so that was a simple example of how we defined every part of the protocol. This is an example of one that was really difficult. Actually, this was one of the ones that in these meetings at the AOS, we could not agree upon, and sort of the loudest person in the room was, it's hard to figure it out. So who was going to be part of this cohort? And so we got 100% agreement that symptomatic stress fracture should be part of it. What about asymptomatic? We didn't get consensus on that. We got 60%. What about stress reaction cases? Patients who had no objective finding, but tenderness along the acromion. And so we didn't get consensus on this. Okay, so you'll see survey 1, October 25th, 2019. Survey 2, we had comments that were put in. And so a number of comments were put in. We should exclude stress reaction as it introduces large selection bias. We should consider a separate stress reaction cohort for those who document tenderness. And one person said we should essentially get rid of it. And so then the question was, can we make this a separate cohort and exclude it from the case? And so we got 65% agreement on that, but not the 80% that we wanted. Next, we went to our next survey, survey 3, and I thought, hey, they'd read this, we'd get consensus. Nope, didn't get consensus, but we did get more comments. And the comments for the last one were one person clearly wanted stress reactions to be part of it. all of this was anonymous. 2 other people said we don't collect it, we shouldn't collect it. And with those comments, we eventually got to agreement that we should exclude it. So we go through every line of the protocol to do this. Again, it's over surveys. People can do this relatively quickly. SurveyMonkey helped a lot. So that's sort of how it worked. It's a lot of time. There is a bias, I will say. There's a bias of the person who's running it, who can put their thumb on the scale here. So that's important to understand. But it was a way of gaining consensus anonymously with us in our own homes without having to meet all the time. So this led to our study protocol. We decided all of these things. Minimum of 3 months follow-up was very controversial. Some people wanted 2 years, but he eventually got consensus, symptomatic, radiographic evidence, excluding stress reactions. And we got a lot of patients, 180 stress fractures, and it led to really good data, an incidence of 3.9%. About a fifth of them were associated with trauma. And, it brought to light that osteoporosis certainly was a factor. Rotator cuff arthropathy as opposed to OA is a factor, along with massive cuff tear. It led to a great paper. This is where that question came up, where do you put yourself? I think for all future papers, it's all going to be alphabetical, but I struggled with this. I think that was a great question. But it led to a lot of momentum. I think people were excited. I certainly was excited. And so momentum leads to wanting to do more. And so now we're looking at implants. We're looking to define the categories implant. Everything was defined by the Delphi process. What is a lateralized glenoid? What's a medialized glenoid? We determined it to 2 millimeters. Again, went through this process. Definitely disagreement on there. We use this same cohort to look at dislocations, which we presented recently. Again, a lot of people, but what I want to highlight here is with all these people comes research assistants and more research assistants, and you need a statistician. Everything Carolyn was talking about. So you need help to be part of this, whether it's a research assistant or administrative assistant. I think you need somebody to be able to help collect this data. And all of these research assistants talk together behind the scenes, which has been very important. So we found dislocation incident was 2.1%, non-unions, revisions, and a history of subluxation. So this is an interesting notion where people who feel they subluxate eventually went on to dislocation. Why this was powerful is there's some people who didn't even believe this existed, and we sort of brought this to light that that's probably one of the most important factors. And we probably couldn't have done that unless we had multi-center collaboration where we all put our dislocations together. So reflections of this, it's pretty much highlighted by what Carolyn did already, but it took me a lot longer to get there, not as sharp. But start small, build a group, have people who are on the same page, who are able to contribute. Consensus is key. I sort of opened the curtain a little bit on the Delphi. There's more to it, but really, maybe there isn't so much to it. You just need to put in the work, do the surveys, be thoughtful about it, be anonymous, be iterative, and really try and nail down the details. RAs are critical. You do need help. Crowdsourcing, basically you're using all the ideas of a lot of smart people. Statistics is key. You're getting the power of statistics, but it allows us to do better work. It's answering important questions that we may have not seen before. And the next step, which we're thinking about, is prospective studies. Carolyn's already done that, but certainly this is the next step that the Delphi process will lead to and what we're thinking about. So thanks a lot.
Thanks, Andy. Great talk. As obviously as being part of this as well, there's no way that I personally could have kind of put this together, and I think that it really speaks to kind of the tremendous work that's been done. And in a sense that I look at this and it's like, okay, I do a lot of research, and this is beyond kind of what I personally can do. And so I think that it doesn't mean that it's not feasible, but it gets to one of my questions, and part of this webinar to stimulate discussion, but also stimulate interest in trying to be able to do this on your own, is that how have you been able to integrate this type of research with the rest of your research and your clinical practice? And meaning that I think it would be important for people to know what your clinical practice is and what the other types of research that you do, to see how that integrates, how this integrates with that, as opposed to maybe other people that do other types of clinical practice research, et cetera, that that might not be able to have the capacity to do this. Because I think if people see a reflection in themselves in what you do, it might give them the spark to be able to do it themselves.
Sure. So I think that's really important. So I'm either lucky or cursed, but so I'm a one-trick pony, and I do arthroplasty. And part of the reason I do arthroplasty almost exclusively, and it wasn't always that way, I was a hand surgeon and beforehand, is because I love research. And I love shoulder surgery and I love arthroplasty, but it allowed me to do something that I loved, but also do research by collecting data and follow-up. So I sort of changed my practice and got guided to this practice in part because I wanted to continue to follow patients and do that all the time. And so this is integrated into how I practice. So literally my follow-ups, and I'm in private practice, I'm sort of private-demic, and it came out of sort of my own pocket to pay for research assistants. And there'll be a side note that I'll make, but those research assistants are medical students. They're people who want to get into medical school. They're out of college, they take a year or two off, they have skin in the game, and they're smart and they can write and they want to do this, and it's symbiotic. We've gotten people into medical school, they've helped me, and it's awesome. So I would say that's the first thing, is having smart people around you, but paying for them. And then part of my practice is literally every day in clinic, I see new patient, 2-week follow-up, 6-week follow-up, a year follow-up, 5-year follow-up. So that's part of what I do, sacrificing some, money along the way in doing that. And everything is clean in terms of the data. Every outcome, every complication, I tell my research assistant who's in clinic with me. And so that's how that works. And then my research assistants literally are in clinic. We talk about ideas. They have to be resourceful and say, okay, what about this? Let's look at our database. Do we have the patients to do this? And they'll be like, no, yes. They'll come up with ideas. It's a back and forth all day, every day in clinic. And it's integral to my practice. It isn't, I go home, I think about research. It is literally every day part of my clinic, part of my OR. And that's a long-winded answer to say it's just what I want to do. And I sort of change my practice.
I think it really helps because it's practicing what you preach a little bit, in the sense that what you do clinically is tied directly to your research. So the reality is the hurdle that you have to get over is much lower, as opposed to, like you said, that if you weren't really actively doing research on your patients and that was critical to it, and your patients weren't necessarily aligned as a clinical population to be able to do it, and then you're trying to do this, this multi-center trial at night when you weren't even kind of practicing it yourself, they would be very hard. And I think that's there's a cost, like you said, to everything that we wind up doing. I was, as somewhat of a side note, that I was giving a grand rounds, and one of the faculty in the audience, after I presented all of this data, they're like, Bob, how do you do this? Like, how you've got animals models, you've presented all this clinical research, et cetera. Like, where do you do this? And I was like, because if I have to do animal surgery, I cancel half a day of clinic. Or if I, if we have to have research meetings, I take 2 hours of my, OR time that I would have done surgery, and we spend it. So you have to sacrifice parts of what you're doing to be able to accomplish what you want to do. And I think that element of the leader in this process, it needs to really shine through, that you can't just, like you said, be a night and weekend researcher, that it really has to be integrated in your 9 to 5 work. And you have to make some sacrifices there. And hopefully to you and to me, it's not really a sacrifice, because we're enjoying what we're doing. Eric or Carolyn, any thoughts or with regards to Andy?
Well, I mean, I would just comment. I mean, I was fortunate to participate in Andy's group too and experience the Delphi process. It was the first time I was really involved in it. It was a great experience and clarifying to see, how effectively it can be used. I think there's sort of a natural way to use it prospectively to kind of figure out the best way to design a study. I think Carolyn highlighted that really well in terms of figuring out the things you want to collect. But I found it really useful with what Andy did, where you're trying to look at retrospective data. And, the challenge when you're getting data from different sites is not everyone's data is exactly the same. And how do you put it all together that you can find useful data that's powerful? And that process very much helped in the retrospective data review to hone down on what everyone knew was most important that they could all collect and that would lead to powerful information. So it was very revealing to see it used in both ways.
Yeah, I agree. I've participated obviously in Andy's, and then the other that I participated in was the PJI work group. And Eric, I think you were part of that as well.
Yeah.
And Andy, I don't know if you were part of that PJI work group, but
it
was through the ASES that met back in 2018 in Philadelphia at the ICM for developing guidelines with regards to the treatment of shoulder infections. And the process was different, and it's interesting. And so this was completely online using SurveyMonkey. We met a couple times meeting with Andy's process, whereas during the ICM, it was basically a weekend process of active discussion, of moving through the questions similar to what you actually did through this iterative process online, but doing it live. And it was extremely onerous and really hard. And it was, I gotta say that Grant Garagos and Andy Green and Jason Shu were the leaders of that. And they did an amazing job of trying to be able to take a group of, 30 plus, I think it was even more, surgeons sitting in a room to be able to go live with what you did on, on the computer and come up with actual recommendations. So I think looking back at both ways, every day and Sunday, again, I would do it the way that you did it, as opposed to trying to work through this process in a live fashion. Anyways, just some thoughts and different.
Yeah, no, and I mean, I think you made a great point on Andy. I mean, it was interesting to see how when you do it online, everyone has an equal voice, and it's not the loudest person in the room, and the loudest person in the room isn't always the best response. So you give everyone an equal voice, and you see the power in that.
I think an important thing for the audience here is you guys went through all the very critical points for doing good research and what components are required. And I think to listeners, a lot of the people may think this is totally daunting. But at the same time, if you have passion for this, this is a lot of fun. And I think one of the things that audience can learn from this is that if you haven't done it before, don't try to start it on your own, because even you may have all the energy and all the resources, there's nothing like experience, and people have gone through this. So it will be a great opportunity for anybody who has passion to participate in this multi-center first before you start your own. I think that should be one of the messages. I mean, people talk about doing research all the time, but they have no idea what it takes. So I think this is a great way to get your foot in the door and get experience, and you can start your own.
Totally agree. You know, it's like anything that until you do it, you don't know. Until you're writing an R01 grant, you have no idea what it's like to actually write one. And so I would agree that any of this, and if you're working in large scale research to try to accomplish things that seem daunting, a lot of times they are, but it's just multiple little steps. And I think that having some experience working in a group, learning these little steps, and then piecing them all together, if something that seems impossible is actually totally doable. So yeah, I would totally agree with you, Ty. Why don't we go? It looks like we're about 8:02. It's perfect. So why don't we go to Eric? Eric's gonna talk to us about current multi-center study opportunities through the ASES and exactly, Ty hit it out of the park, how to get involved. So how do we get people involved in these studies so that if you want to get up, on the starting level, to then potentially learn the ropes to be able to do this on your own, this is a perfect opportunity.
Thanks, Bob. So yeah, I'm going to talk about some of the ways to get involved in these multi-center groups of the ASES, and I think reiterate a lot of the points that have already been brought up both by Carolyn and Andy, and also use some case examples and experience I've had in the multi-center groups about working through this process, similar to what Andy did. So my disclosures are on the Academy website. And just as some background on how these groups formed, in 2017, the executive committee created this ASES Multi-Center Research Task Force to try to foster multi-center research efforts in the society. And you can see the original task force members here, and Jed Kuhn was the chair of this task force. And through their work, led to the development of these groups. And in 2018, the shoulder groups were formed, followed by in 2020, the elbow groups were being formed. And because of the early success of these groups, this task force has become a current and permanent committee. And Jed and Carolyn are now the co-chairs of the Multi-Center Research Committee. And at this point, there are now 18 multi-center research groups studying different aspects of shoulder and elbow disorders. And I'm just going to highlight the different groups that are currently active right now. On the shoulder side, if we look more on the soft tissue side, we have an acromioclavicular injury research group, a SLAP lesion and biceps pathology research group, a partial thickness rotator cuff tear research group, a massive rotator cuff tear research group, and then a shoulder instability with bone loss research group. And then looking more on the side of arthritis and arthroplasty, we've got a number of groups, including a natural history of glenohumeral osteoarthritis research group, shoulder arthritis in the young patient research group, a B2 glenoid research group, Andy's group that he highlighted, complications of reverse shoulder arthroplasty, a PGI revision arthroplasty research group, and then a proximal humerus fracture research group. And then similarly, there's been a number of elbow groups that have been started as well. These are a little newer and still building, but on the soft tissue side, there's an elbow stiffness research group, an elbow soft tissue injury research group dealing with lateral side injuries, and then an elbow medial instability ulnar collateral ligament research group for the medial side. And then similarly looking at bony pathologies and fracture, there's an elbow arthritis in the young patient research group, an elbow arthroplasty research group, an elbow fracture and dislocation research group, and then an elbow OCD lesions research group. And the simplest way to get involved in these is reach out to our co-chairs, both Jed and Carolyn, who have organized these groups. As I said, the elbow groups are on the newer side and still building, so there's a lot of opportunity to get involved in those. But even though the shoulder groups are more established, the shoulder groups are also looking for engaged members, and Jed and Carolyn can get you in touch with each of the group leaders. And, similar to what Carolyn highlighted is, what do you need to do to be involved in these groups? And if you look across all the different groups, there's different ways to be a participant and even a leader in looking at different research questions. And all of these groups have tried to look at different aspects of research design, including performing systematic reviews, different consensus and agreement studies, reliability studies. Andy highlighted the work he's done on looking at retrospective data review, and then sort of the ultimate level is to move to prospective multi-center data collection. And, what are the benefits of these groups? Again, this has been highlighted. These multi-center groups have the ability to collect powerful data and have the ability for you to participate in high-level research, things that, Ty was just reiterating. You may not be able to do these on your own. You have the power of a group over an individual, and this can lead to improvement in your practice and outcomes. It can get you more academically involved with regards to publications and presentations, and ultimately even academic promotion. And it builds lifelong relationships with your colleagues and friendships. So, as I think Carolyn highlighted really nicely, what is required is being an active and engaged individual in the group. You need to be engaged in the work. You need to be flexible and adaptable with what you're willing to do, to be committed to the research, be responsive and have passion. And this can be in all these different ways. You want to attend meetings when they're held, attend conference calls when they're held. You want to do your work in terms of completing your forms and surveys, reviewing images for reliability studies or consensus studies. And then as you move to the more challenging prospective data collection, making sure you have your IRB active, enrolling patients and doing appropriate follow-up so you can get that high level long-term clinical outcomes. And then as Carolyn highlighted, contributing to manuscripts. And, I think as all these groups try to move to prospective data collection, this was also highlighted. It's important to have personnel in your own practice for being able to participate in these studies effectively, whether that's a research coordinator or some other type of research assistant that can help with getting IRBs, getting patient enrollment, following up, making sure forms are completed, and then having a very good data collection system. These groups have developed data collection systems for the group, whether it's with REDCap or commercial databases. But if you have your own data collection system, it's going to allow you to better integrate with what the group is doing. Now, as sort of a way to highlight some of what's going on, I thought I'd go through a case example of some of the work I've been able to be involved with. I'm the group leader for the B2 group, and this group consists of 35 members. And we, as Carolyn highlighted and Andy highlighted, wanted to look at some initial questions around surgeon variability when looking at the B2 glenoid with both diagnosis and management. So our two early studies that we wanted to look at was the reliability of the modified Walsh classification. And we wanted to do this at a very high level using advanced 3D CT imaging. And then we wanted to look at practice variation with how the different surgeons in the group manage the B2 and B3 glenoid. And the goal was to build from these levels of looking at consensus and variability to ultimately prospective multi-center data collection. So I just wanted to highlight in particular our study looking at the reliability of the modified Walsh classification. And our goal was to look at intra and inter-observer reliability with the modified Walsh classification when looking at the classification as a whole, but also this group of cases that we were most interested in, these posterior glenoid deformity cases, whether they're the B2 or B3 glenoid. And our first step was to establish a multi-center IRB to allow us to collect data together and create a mechanism of looking at de-identified CTs across the group. And we actually came up with a way to develop this secure web portal that the entire group could access to be able to look at three-dimensional CAT scans in a consistent way across the group. And we use REDCap as our data collection system to be able to do this well. So we ended up generating the first group of cases, looking at the entire classification with 96 cases, and then a group of 98 cases for the posterior deformity group. And our goal, we had hoped, was to try to get 5 to 10 members of the group to be involved with each of these two case groups and do at least 4 reviews of these cases over time, twice without what's called the glenoid vault model that I'll show in a second, then twice with the vault model to be able to look at both intra and inter-rater reliability. And in order to have consistency in how we were all grading these different modified Walsh classifications, we created a consensus definition for each Walsh type, which included a consensus study manual of cases using 3D CT of what a classic case of each modified Walsh type would look like. And you can see an example of how this web portal looked here. If you look at the image on the right, this red outline is what's called the glenoid vault model, which is a preserved bony glenoid vault that allows you to appreciate the premorbid anatomy of a pathologic glenoid, so you can see where the areas of bone loss are in these cases. And you can see a live video of how this web portal worked that allowed us to all access these 3D CAT scans to look at the CAT scans in both 2D and 3D and see what the pathologic measurements were with regards to version and inclination. And I'm not going to get into the details of the data that much, but just to briefly highlight this, I was amazed by how excited the group was to participate in this study. I was hoping we would have 5 or 10 members participate in each of the case groups, and we actually had 23 of the group members participate, 12 looking at the group 1 cases, 11 looking at the group 2 cases. All of these members completed 4 different reads of these cases. And you can see that we found that the modified Walsh classification has fair to moderate agreement when you look at both groups of cases with or without the glenoid vault model. When we look closer at intra-observer reliability, we actually saw better intra-observer reliability with it improved to the level of substantial agreement, particularly when looking at use of the vault model. And then we looked at the individual modified Walsh cases. We actually found that the B1 glenoids had the lowest level of reliability. The B2 glenoids had the highest level, probably because they have the characteristic biconcave appearance, and that the D glenoids, or the cases with anterior bone loss, had the most improvement in being able to be identified when the vault model was placed. So this was a nice initial study to bring the group together. And then, not to get into the details of this follow-up study, but we created this follow-up study looking at management of the B2 glenoid across the group. And we utilized the structure of our initial study. We had established a multi-center IRB and this web portal to be able to look at de-identified 3D CAT scans. And we used the same structure to be able to present these cases to the group. So we built upon the work we had done in the first study with this second study. And after looking at the initial studies, I think the ultimate goal for all of these groups is trying to move to prospective multi-center data collection. And we've talked already a bit about the challenges that can occur when trying to develop this across a large group. And our goal initially was just to broadly be able to look at prospective cohorts to determine factors related to clinical and radiographic outcomes in these B2 and B3 glenoids with regards to surgical management. And we tried to start to answer these questions using red cap surveys, similar to what Andy and Carolyn highlighted, with getting group consensus around the potential number of cases we were going to have, what type of inclusion and exclusion criteria we would have, and the data collection tools we would use. And I think by going through this process, it brought out some of the challenges you can see when you try to build a multi-center group that has prospective data collection. I think one of the things we saw just in surveying our group with the data we collected at baseline is we realized how variable retrospective data could be across different sites with regards to PROMs you collect, follow-up rates you collect. And that led us to realize that we need to have good consensus on the prospective data we will want to collect moving forward. And then when looking at prospective data, particularly in the setting of shoulder arthroplasty like this group, we realized that short-term data may not really show large differences between these groups, and the challenges in these arthroplasty cohorts, we may really need to look at longer-term follow-up with regards to PROMs, rates of loosening and revision, to really see difference in these different cohorts over time. And then when looking at that and realizing that you need longer-term follow-up, how big a sample size of study patients do you need to achieve the goals of a study? And I think going through this process led us to realize that if we wanted to follow one particular group well prospectively, we needed to hone down on a more narrow group of patients that we thought we could collect really well, rather than just try and look at all comers with this disease. So this was a very good process to go through. And then how do you go about reaching consensus on how this data is collected? I think Carolyn highlighted this nicely in her talk. I just showed that our inter-observer reliability for the Walsh classification is not very high. So how do we develop mechanisms that we have a consistent rate across the group of identifying these cases? How do we develop standard methods to measure things like range of motion X-ray analysis. And then if you start looking at radiographic analysis, which is important in shoulder arthroplasty, how do you actually collect and store this data? How do people send their X-rays or CAT scans to a central site so that they can be stored and analyzed in a consistent manner? And so one of the things I wanted to highlight at the very end, and Bob, I briefly alluded to this, I think the group that's done the best job so far in developing an active prospective multi-center database is the PGI revision arthroplasty group that's been led by Jason Shu. So this is the one group currently in the multi-center groups that has had active ongoing prospective data collection for more than a year now. And the group started in a similar manner as the other groups that looked at some initial projects around variability when looking at culture analysis and revision arthroplasty. And you can see these initial studies here, and then move to develop prospective multi-center data collection. And I think one of the things that was really important for this PGI group is it had the ability to look at questions around diagnosis with prospective multi-center data collection that have the ability to be answered almost immediately and don't require long-term follow-up. So this was a great way to be able to get into prospective data collection almost immediately. And Jason was I was very fortunate for Jason to be able to share some of these slides of that he presented at our most recent research group. And you can see the success that this group has had with regards to multi-center data collection over the last year and a half. And you can see the power of data collection, as Andy highlighted earlier, when trying to look at a question like diagnosis of infection, which is not that common in shoulder arthroplasty, and how this large group allows you to collect fairly large numbers quickly. And one of the important parts of coming to how we were going to collect these cases is what's already been highlighted. We developed this group consensus around the cases that we would be collected. We decided that all consecutive revision arthroplasties would be collected, not just infection cases. We were only going to enroll patients that were starting at the process of first stage revision and not picked up at the point of second stage. And you can see what we decided were the most important data points to collect at revision with regards to our OR aspirations, frozen section analysis, and then tissue cultures taken at surgery. And you can see a highlight here of what Jason presented recently at our meeting at the ASES annual meeting in terms of the amount of data that's been collected so far. And as I said, the power you can have with multi-center data collection to be able to ask questions that a single group may not be able to answer. So that's the current work the group is doing around diagnostic testing and analysis, and the long term with this group as well is to move to prospective outcome collection with follow-up at 2 years or more, looking at recurrent rates of infection, revision, and PROMs. And I think Carolyn highlighted this is as you move into long-term data collection with these groups, the challenge is how do you fund these groups long-term? And I think ASES already has some great opportunities for funding to help get these groups growing. If you look at the different ASES grants, all of these grants are opportunities for these multi-center groups to get early funding. The proximal humerus fracture research group has recently had an award for an ASES research grant to start their prospective multi-center data collection. And ASES and the Academy, through work by both Jed and Carolyn, is also trying to develop opportunities for larger scale multi-center research funding moving forward for these groups. So as I said, these are great opportunities to get involved. And if you want to get involved in these groups, reach out to Jed and Carolyn, and please join. So thank you.
Thanks a lot, Eric. Great summary, interesting data from two different groups. And look forward to see some really interesting things. It's interesting that the ICM work group or process came up with the kind of criteria that Jason is now using to be able to further with another large group to be able to actually validate it. So it's taking a big group that came up with a criteria to then take it to another big group to see if it's actually valid and how we can use it. So I think that's a really exciting thing about the PGI group in particular. There was this consensus criteria from that meeting. Yep. That it's, the group's a great way to answer some of those questions around those consensus criteria. where, for people that are online, is there a location on the ASES website with regards to each of the groups and kind of a snippet with regards to what they do, or not, or that information is not kind of currently available? It's only through emailing Jed or Carolyn.
Yeah, I would say the best way to reach out right now is by emailing both of them. Carolyn, do you want to add anything to that? The website does not actively have anything specifically about the groups, but I mean, I think the best way to get involved is to reach out to you guys, correct?
Yeah, that would be the best way right now. There are some groups that are actively looking for more members. And if you have a specific interest in one of the groups, we can get you in contact with the leaders to see if they're taking on more people.
Okay. Second question is, do you need to be an ASES member in order to actually participate?
That was the goal of the groups. So that was the case initially with enrollment. Caroline, do you want to answer that question?
I believe that is the goal. I mean, the question has come up with some of the conditions that involve pediatric patients and involving maybe some people that are outside of the group. But as of right now, I believe everyone is a member of ASES, but that's something that could be discussed.
Yeah, actually, that's a great point. You know, the OCD elbow group, because of the involvement on the pediatric side, Mohit Galatra, who leads that group, has had some interactions with some of our pediatric colleagues because of the fact that that condition spans multiple societies.
Mm-hmm.
And the other thing with regards to that is that oftentimes it might be, aligning with someone that is actually an ASES member. And I don't know if that has been discussed, that maybe you might not be an ASES member, you might be a partner with one, or you might be a resident or a fellow, et cetera, that's working with one that trying to get people interested that want to do research, it would be unfortunate for them to not necessarily have access to it.
And I think, it's good. Sorry.
The question would be, is there a membership category which some of these people might be able to
Absolutely
join ASES? And while they might not be able to be active members, could they be something else?
Absolutely. And because the threshold with regards to candidate membership is changed, that whether it's candidate member or resident or fellow, I believe there's resident fellow member classification, if I'm right, with regards to that I think probably access within the world has gotten much easier, and therefore potentially made the opportunities more available. So again, I would probably it's great that someone would want to become involved in these types of studies, but it's also an entryway to join ASES that if you aren't necessarily part of it currently. So
yeah, and I guess to clarify, any level of membership of ASES can be involved in these studies now, whether you're at the level of active, associate, candidate, fellow. And yeah, you can see people get involved early and progress through membership as they're involved.
Okay. What's from a timeline for most of these groups, what do you think the next time that they're going to meet? Is it academy, or is this something where a lot of these groups are meeting on a more frequent basis? So for people that might be involved that want to get, what's the entry point? Do you think it will be AAOS and that they should kind of make plans to be there, or is it something sooner, or is it different based upon the groups?
I think if you're interested in any of the groups, reach out, and you can get in touch with any of the group leaders and they'll let you know the cadence of what's going on, the schedule. And the groups all try to meet in person at the major meetings like the academy and the ASES, but based on the projects we have going on, there's active meetings between those in-person meetings if there's active projects going on with either Zoom meetings or frequent emails if there's an active project going on. So there's always opportunities to get involved at any point during the year. I don't think you have to just only get involved at an in-person meeting. It's whatever time you want to get involved, you can.
Okay, it's great. Peter McDonald had just messaged in that He'll try to add some information onto the ASES website. So that'll be very helpful, maybe even just small snippets with regards to each of the different work groups that it would, I think it would add a lot, that it would, expose people to this even more, to even, I mean, honestly, half a dozen of those, I didn't even know that they existed until you actually showed them on the screen there myself. So I think it's, I think that would be very valuable for exposure for these.
Carolyn, did you want to, I mentioned it briefly. Did you want to talk at all about this potential relationship with the Academy? Because I think that's sort of an intriguing thing for the potential of larger scale multi-center funding. I know some of that's happened with AOSSM to this point.
So the Academy is providing money to BOS and BOS groups, in which the different BOS groups can ask the Academy for funding for different research projects. And that can be done, individually with each group, either like sponsoring certain, projects from their society, or it can be done like they did with AOSSM, where the Academy promised them a certain amount of money, then AOSSM led their own search to identify multi-center research project in which they could fund, and AOSSM was able to do that at $400,000. So we are trying to do something similar, whether it be for one of those two mechanisms with ASES. And what the Academy is wanting to have done is they're wanting to put forth a certain amount and have the society match that money. And so, we've requested 100,000 from the Academy, hoping to then get a matching grant from the foundation, ASES Foundation. And that $200,000 would be a good chunk of money that could really help one of these groups pay for some research staff, statistics, et cetera, and really get going with their prospective data collection. And so that's one of the big things that we're working on now, is trying to, help people clear that funding hurdle.
It's great. I think if we can, anything that drives momentum towards actually getting funding towards these, it will push even more funding. Typically, that the other groups will see that other groups are getting funding, and so then they'll want to get funding, and then they'll go. So I think it's trying to get over that initial barrier is key to making these groups more successful, and answering bigger questions. And what would be really amazing is that if there was high level funding, a large scale government funding that is directly linked to a society that was from a society driven project, not like Moon or other kind of non-society. This is stimulated through the ASES, and I don't know of any other society that has had a program or project that then has been able to secure large scale government funding through something that's been created internally. And I would say that would be a pretty amazing accomplishment.
Yeah, it's actually interesting, Bob. So one of my colleagues here at Cleveland Clinic, so the Hernia Society has actually done this. So one of my colleagues, Mike Rosen, him and a group of the surgeons in the society actually built a hernia registry, initially funded by the society, that has become so successful that it's now used for data collection across the whole country, but also for FDA clearance things now. So they actually get government level funding for things like that, and it's been highly successful, and initially started just like what the ASES is trying to do, a society funded study that was able to then get its own funding after building enough momentum.
Sure. It would be an amazing accomplishment. So it looks like we're kind of at the end of our hour and a half. Any final thoughts from anyone that would like to say a couple words, or it's okay, we can close it out as well.
I would just quickly like to reiterate what Bob said earlier, and that, a lot of this stuff seems daunting, but it's a lot of fun. So once you get going in these groups are a lot of fun to participate in when you're talking about the study design and debating, and when you start to analyze data. I mean, it's really rewarding, and it really is worth the effort.
I'd reiterate that and just say that we could really answer questions, which in and of itself is exciting, that we just can't do individually, which historically in orthopedics as a whole and shoulder and elbow we've done. And so I think we're turning the corner, and this is really a great start. This webinar has been great for opening my eyes as well. So thanks for putting it on those comments for me.
Yeah, I agree as well. I mean, it's really exciting. And I think, the kind of exciting thing is, can you move to the level of looking at some of this data long-term and really looking at large numbers of long-term outcomes?
Yeah, and I think the multi-center groups are doing a great job. I mean, Andy and Eric are both doing a great job with their groups, and are one of the ones that'll be primed to getting kind of this future funding. So it'll be great to see what's coming.
It's perfect. I want to thank you for taking your evening and time away. It's been, I think, a tremendous webinar. This has been videoed, the entire webinar. All three of our webinars have been videoed, so it'll be accessible to people that were not on tonight. And we're trying to make this as part of this video library that is available. So this will be useful information moving forward for people that are interested in looking at starting large-scale clinical research. Don't feel that this is off in the ether that will never be seen again, because this will be a useful resource for people that are interested in pursuing this line of research. Again, I want to thank Carolyn. I want to thank Andy and Eric for great talks. And this, for at least 2021, is going to conclude our
2022.
Sorry, 2022 conclude our research webinar series. And we will be putting together another series of these for 2023 with potentially some other topics. And I would always take recommendations from interested parties of things that they might want to hear about, and they can just email me directly as to various topics for future webinars. So again, thank you again. And with that, we'll say good night.
Thanks, Bob. Thanks, Ty.
Thanks,
Thanks all.
everybody.
Bye. Thanks.